All right, welcome everyone. Today, we're going to play detective and dive into a really fascinating medical mystery, the curious case of the sleepy bowel.
So picture your digestive system as this constantly moving freight train. Let's call it the poop train. It's always working, right? Clearing out food, secretions, dead cells, the whole shebang. But what happens when that train suddenly, for no obvious reason, just grinds to a halt?
Well, in the medical world, this has a name, Ileus. It's the official term for when the bowel becomes paralyzed or sleepy, and all that normal forward motion, we call it peristalsis, it just stops. So the big question is, why? Why does it happen?
And that's a perfect lead-in to our first section. We're going to investigate the mechanics behind this and figure out exactly why this super important system suddenly decides to just shut down.
Okay, so it all boils down to something called the migrating myoelectric complex. Now that sounds complicated, but you can just think of it as the electrical system that powers our poop train. And here's the thing. This system is surprisingly sensitive. It gets offended really easily. And when it gets offended by some kind of trigger, it just cancels peristalsis. It shuts the whole operation right down. So, what could possibly offend this system? Well, a whole lot of things actually. Common triggers can be anything from inflammation and infection to trauma or even certain medications. But the classic offender, the one you'll hear about most often, is surgery. A postoperative ileus is a super common reason for the bowel to decide to take a temporary nap.
Let's keep moving. Now this is where it gets more interesting, because this standstill doesn't just come in one form. It turns out there are two main flavors, and telling them apart is a really key part of the diagnosis.
These two types are called generalized and reactive, or you might hear it called focal. In a generalized ileus, the entire bowel is sleepy. You'll see air spread out through the whole thing. But with a reactive ileus, the shutdown is local. Only one specific part of the bowel is affected, usually because something right next to it is causing trouble.
And this quote right here, it's a huge clue for spotting a generalized ileus on an X-ray. Because the entire system is uniformly asleep, air fills up both the large and the small bowel, and they start to look very, very similar. It's a total telltale sign of a widespread shutdown.
Now, for a reactive ileus, the big clue is totally different. You're looking for something called a Sentinel Loop. This is a dilated, air-filled piece of bowel that's basically standing guard right next to an area of inflammation. It's reacting to a local problem, kind of like a loyal sentry. And what's really cool is that the location of that Sentinel Loop can give you a massive clue about what's actually causing the problem. For example, if you see a loop down in the right lower quadrant, you're going to think appendicitis. If it's in the central abdomen, maybe it's pancreatitis. And one over in the left lower quadrant could point to diverticulitis. The bowel is basically telling you exactly where the trouble is.
Okay, this brings us to the most critical part of our investigation. We absolutely have to be able to distinguish our sleepy bowel, the ileus, from its number one imposter, a mechanical bowel obstruction. Remember, one is sleepy, the other is stuck. And that is a crucial distinction to make.
The visual clues you see on an X-ray are pretty much everything here. With an ileus, the dilation pattern is symmetric. Air is pretty evenly distributed everywhere. But with an obstruction, it's asymmetric. You'll see a lot of air and dilation in the small bowel right before the blockage, and then very little air in the large bowel after it. Let's get even more specific. On a supine X-ray, that's when the patient is lying down, an ileus shows up as these kind of disorderly, messy loops scattered all over the place. An obstruction, on the other hand, presents with these dilated loops that are arranged in a very orderly step-ladder pattern as they stack up against whatever is blocking them. And what if the patient is standing upright? Well, the clues change again. An ileus will usually show just a few small, scattered air fluid levels. But an obstruction, you're going to see many very distinct air fluid levels in those dilated loops, and they can create a classic visual sign that radiologists call candy canes.
We are almost at the end of our case file, but there is one final, really tricky scenario that we need to decode. It's a twist that can confuse even the most seasoned detectives.
What happens when you look at that X-ray and you see basically nothing? No gas, no clear loops. This is what's known as a gasless abdomen, and it is a real diagnostic puzzle. A gasless abdomen is so tricky because it's nonspecific. It can be caused by two completely different things. It could be a bowel just full of fluid from something like diarrhea,
Or it could be a bowel full of fluid because of a serious obstruction. The X-ray image alone just doesn't give you the answer.
So how do you solve it? Well, this is where that good old-fashioned detective work comes back in. When the imaging is ambiguous, clinical context is everything. You have to look at the patient's story, their symptoms, their history. That's what's going to crack the case.
And that brings us to our final, most important takeaway. When you're faced with dilated loops of bowel, the ultimate question you have to ask is always this: is it sleepy or is it stuck? And now you know that by carefully examining all that visual evidence, the distribution of gas, the symmetry, the patterns, you can find the answer.